Hello, everyone, and welcome to the 2020 Rural Health Clinic Workshop presented by the Oregon Office of Rural Health. My name is Rhonda Ann Gerst, and I am the Rural Health Clinic Program Manager and will be the moderator of this session today. First, I would like to thank our partners, Gold Partners, All Care Health, and Oregon Rural Health Association. Silver Partners, Eastern Oregon Coordinated Care Organization, Oregon Association of Hospitals and Health Systems, and Riverhouse on the Deschutes. Bronze Partner, RQI, and our Copper Partners, Westcom, American College of Education, and INQUISEEK. Their continued support during these difficult times has made it possible for the Office of Rural Health to offer this conference and workshop at no cost to you. Session evaluation. After this session, you will receive a survey. Please help us continue to make improvements by completing the survey. In addition, this is how you will receive your CE credits, and you will be entered in a drawing to win a $100 gift card. To present, Federal Rural Health Clinic Policy Update and What to Expect After the Election, please welcome Nathan Baugh, Director of Government Affairs at the National Association of Rural Health Clinics. Nathan, the floor is yours.
Thank you, Rhonda Ann. And thank you all for being with us here today. As Rhonda Ann mentioned, I work with the National Association of Rural Health Clinics, and I will be giving you guys a Washington update. And this update will be a little bit more retrospective looking and not as much looking forward to the election, because the election's about to happen, and I don't have a crystal ball to predict, but I will by the time you guys see this. So anyways, we'll be talking about the federal response to COVID, the telehealth policies that were put in place as a result of COVID, and where we go from here on those fronts. So for context, it's important to understand that the federal government spent more money in response to COVID than they spent in response to the financial crisis of 2008, 2009. Okay, so the scale of what the federal government did is massive. You've heard about, you remember that we all got a $1,200 check if you made less than $75,000. You got more money if you had kids. That spending was a part of the CARES Act. You had the Paycheck Protection Program, which was a massive, many billions of dollars, hundreds of billions of dollars in the Paycheck Protection Program. And a part of that, a significant part of that spending was $175 billion for healthcare providers in what we call the Provider Relief Fund. I'm not going to get into all the details of the Provider Relief Fund. Those are perhaps deserve their own presentation, other than to tell the folks that are watching this webinar that you should be aware of the allocations that your healthcare system, your rural health clinic, your hospital received from the Provider Relief Fund. And you should be aware of how many allocations you received, how much was the allocation, and what that allocation was for. Why did you receive it? Okay, so that is my overarching guidance on the Provider Relief Fund. I do want to dive into a few specific allocations just to help orient yourself, the discussion here. The first payment was what they call the general allocation. And this was something that went out in April and was 6.2% of your Medicare reimbursement in 2019. Okay. That was the first payment because the federal government had Medicare data from 2019 ready at their fingertips. Obviously, for those providers that don't have as much Medicare, have higher mixes of other types of patients, that was unfair. So their second payment out of that general allocation was 2% of the 2018 net patient revenue minus what you got in round one. So everyone was supposed to get up to this 2%. Now, by the time you listen to this, it might be too late. There is a third round of what we call general allocation payments. That is, the deadline to apply for that closes on November 6th. So there is another round of payment coming out of this general pot. And if you want to apply for that, you have to apply by November 6th. Okay, so that's the general allocation. Everybody got that. Almost everyone in the healthcare sector. For rural, there were two specific allocations. One of which, the rural distribution, was a part formally of the Provider Relief Fund. Okay. The other allocation that you received was the RHC Testing Fund. And this, very importantly, is actually not a part of the Provider Relief Fund. It is not a part of the $175 billion Congress allocated to the Provider Relief Fund. It is, in fact, a separate line item that was $225 million just for rural health clinics. Okay. That's important because it's actually a different agency that's administering the RHC testing. However, if you read the law, and what Congress did is they said basically that they should follow the same steps that were established for the Provider Relief Fund to administer the RHC testing fund. So, if I haven't confused you already, in some contexts, the Rural Health Clinic Testing Fund is lumped in with the Provider Relief Fund. In other contexts, it's not lumped in. Okay? All of this is to say that it's going to require a little bit of effort on your part to understand what funds you received when, for what purpose. And the Rural Distribution Fund, that is definitely a part of the Provider Relief Fund, that was a more significant amount of money. Independent rural health clinics received a minimum of $103,000 per RHC, and then there was an additional amount that you would receive based on your operating expenses. If you're part of a system, the methodology does get a little complicated, so I'm not going to get into it here, but you received a good amount of money, and your system received more money because they owned rural health clinics. So that money was distributed in early May, about May 6th, and that money gets lumped in with the formal Provider Relief Fund funds. RHC Testing Fund was delivered at the end of May and is a different fund administered by a different administration. You'll see why that distinction is so important in a second. Last thing I have on this slide is that the good news is that there may be another round of funding in phase 4. Regardless of what happens next Tuesday in the election, there will likely be some path for a fourth round of COVID-19 stimulus at some point. The timing and the size of that does probably depend on the election, but most observers do project that at some point, once the dust settles on the election, we will get a fourth round of COVID-19 fiscal stimulus. In some of the early drafts for phase 4, there was another round of $225 million for rural health clinics for testing. In some of the drafts, there wasn't that. I could easily see that if phase 4 gets delayed past when we have a vaccine announcement, that they in fact don't fund rural health clinics for testing, but they'd rather fund rural health clinics for vaccine distribution. So good news is that there's a chance, hopefully a strong chance, that RHCs and systems that own RHCs will get another round of money. I don't know when, I don't know how much, and I don't know for what purpose, but I do think there is a good chance that we'll get something. The bad news is that that's, of course, just going to complicate things more between all the different allocations that your system or your rural health clinic may have received. Next slide. My best advice when you're assessing these allocations is to do two things. The first thing you want to do is look at the terms and conditions of the money to figure out what you can spend it on. The second thing to do, because the terms and conditions were quite frankly written very quickly, the government moved very fast in response to COVID, perhaps too fast, and some of these loose ends were not tied up. They opted for speed over perfection, and that shows in some aspects of the program, particularly in the terms and conditions. So the FAQs are a little bit more readable and provide a little bit more guidance. And those are the next place to look when you're trying to ask yourself, what can you spend the money on? And what's appropriate and what's not. Okay. For the provider relief fund of money, and I have the FAQ link there. The key phrase there is healthcare related expenses or lost revenues that are attributable to coronavirus. That's a quote from the terms and conditions. Okay. So that's a pretty broad category of lost revenue or healthcare related expenses attributable to coronavirus. Now, the provider relief fund definition of lost revenue has been changed 3 times already, and it will likely change going forward or be clarified again going forward. There was a definition in June that was announced on what lost revenue meant. In September, there was another definition that came out that the healthcare community really disliked because of the way they defined lost revenue. And the backlash was such that HHS actually relented and went back to their June definition of lost revenue. So that whole, what you can spend that money on and what classifies as lost revenue is still a little bit in flux, okay? The RHC testing fund money, you'll note that the FAQ for the RHC testing fund is a HRSA.gov website, not a HHS.gov website, right? That's because, like I told you, there are different agencies responsible for this. And the RHC testing money is not technically a part of the Rural Provider Relief Fund, okay? The key part of the terms and conditions here is that the 49.5 grand per RHC is that is for COVID-19 testing and COVID-19 related expenses, not for lost revenues, COVID-19 testing, COVID-19 related expenses. Next slide, please. So one of the major distinctions between Provider Relief Fund money, HHS.gov FAQ, RHC Testing Fund money, HRSA.gov FAQ, is the fact that they have different data reporting requirements, data collection requirements, okay? The testing fund, the HRSA money, 49.5 per RHC for COVID testing, that reporting will be done on www.rhccovidreporting.com. Okay? That is going to be different than the provider relief fund reporting. That portal will open up in January of 2021. and HHS is working on creating that portal. But RHCCOVIDreporting.com is up and live currently. Full disclosure, the government contracted with me to create RHCCOVIDreporting.com. So I tried to create it as easily, let me rephrase. I tried to create it in such a way that would make it as least administratively burdensome as possible for RHCs. And hopefully when you log in and you go through the steps, you'll see that that's reflected. We have a whole webinar walking folks through from A through Z on RHCCOVIDreporting.com, which is freely available at our website. And so I have the instructions of how to get to that on your screen. I do want to go over just a couple of the major questions that I always get asked about this. Technically, rural health clinics were not paid for the COVID-19 testing program. The tax ID organization that owns the rural health clinic was the entity that was paid, and that is the entity that is responsible for reporting and could decide where the money went. So the data, we're asking for the data to be organized at the tax ID level, not at the RHC level. Because, for example, if you had one hospital, one RHC, they're both part of the same 10, that 10 organization was allowed to spend all the money at the hospital and none of it at the RHC. That is permissible. And so we want the data from testing across the entire 10. Hopefully that's clear. It's very simply, we want testing data by month. You don't have to give us days. And it's a very quick and easy data portal. This is not going to be used for the public health purposes. This is not going to go into the numbers that get reported daily in the media. This is simply to evaluate the $225 million Congress allocated to organizations that owned rural health clinics. It is required. We got OMB approval. It's required in the terms and conditions. So you do have to create this account. If you don't do it, you're opening yourself up to potentially forfeiting the money down the line, potentially in an audit. We're here to help you with that. And I could talk all day about the data reporting, so I won't. Feel free to contact me if you've had problems either with registration or questions about what you need to report. Next slide, please. Okay, so as I mentioned, the RHC testing fund is taken care of by RHCCOVIDreporting.com. All that provider relief fund money that HHS is administering, the reporting for that will be a different process. I have the little memo that HHS put together. HHS didn't contract with me to create this data portal. This is the data portal that covers all 175 billion of that provider relief fund that everyone has to grapple with. So this is in HHS's hands. And they currently have the portal for the data reporting there scheduled to open on January 15th, as you can see on your screen. And it's going to be a little more focused on the finances a little bit. I don't think you're going to be reporting testing data in this portal, but rather financial data. So I'm frankly not the expert on what HHS plans to do in January, but I'm sure Oregon Office of Rural Health and others will put out more technical assistance as we get closer to that January 15th date about what you need to do to report on that other money that you've received. Next slide, please. We've also, it's a little, the email address at the bottom is a little grayed out, but we've contracted with NOSOR to help us provide technical assistance on the RHC testing fund. And they can help you with any questions as well. And their email address, which you can barely read, is RHC COVID testing info@nosor.org. And that's a resource for RHCs directly, systems directly can reach out to that email address. Obviously, state offices of rural health can also reach out to that address if they have questions as well. So just wanted to put that out there. Next slide. Real quickly, I debated removing this, before, but I do want to mention it before we move on. Cost report and tax implications for all of these allocations. If you're a nonprofit entity, you don't pay taxes, nothing changes. If you are a for-profit entity, and you got the Provider Relief Fund, which I presume most of you did, that money is taxable. Okay, so just prepare for that when you're doing your taxes this year. If you got Paycheck Protection Program money, however, that money is not taxable. So that's just an update there. But more importantly, on the cost reporting, we had major concerns that all of this funding, whether it would be Paycheck Protection Program, Provider Relief Fund, or RHC testing program, all of this money that RHCs and the organizations that own RHCs got, would that reduce the amount of money that they can claim on their cost report? So we were very concerned about that because essentially it would lower the amount of the stimulus that rural providers got, and it would cause this weird ricochet effect where you would be underpaid potentially next year or in 2022 because your expenses were offset. So bottom line is that we were very worried about this, and it would have amounted to us having to owe some of that money back to the government. But thankfully, HHS listened to us. NRHA was helpful on this as well, National Rural Health Association. And we really pressed them not to force us to offset our expenses by the amount of the money received. So as you can see on your screen, I have the link to the FAQ where the federal government clarified this. And they say, as you can see, should the SBA loan forgiveness amounts, that's the Paycheck Protection Program, offset expenses on the Medicare cost report? No. Should Provider Relief Fund payments offset expenses on the Medicare cost report? Answer: no. Okay, so that means that you can have your expenses, reflect your expenses without reference to any allocation that you received throughout 2020. So huge win for us. We are happy to see that happen. Next slide, please. So that's my piece on the different allocations, and we're going to switch gears here greatly to talk about telehealth policy. But I do want to maybe put a button on the different allocations, which is just remind people that there was a ton of money. One, they got the money out there very quickly. Two, we're starting to deal with some of the consequences of that speed and, quite frankly, inaccuracy now. It's no one's fault that we're kind of now filling in the rules and the guidance to money that was delivered in May and April. That's just the nature of the crisis at hand. We're trying to do our best to make sure that the rules, the details that are getting colored in now by the federal government are fair for providers, and we're trying to make it as simple as possible. But of course, when $175 billion goes out, there's gonna be some transparency and some reporting requirements. So it's a bit inevitable that we were gonna have to do this. So we're here to help, particularly on the RHC testing fund, which was specifically targeted to RHCs and we're very actively involved with helping the government evaluate that program. We're here to help on all of it, and hopefully we get some more money, and in the next round of money, whether it's for more testing or for vaccine distribution, we will have learned some lessons and have some of the terms and conditions and things cleaned up in phase 4. So with that said, I'm going to put a pin in federal stimulus to the COVID-19 crisis and switch gears greatly and talk about telehealth. The picture on the screen is obviously a long road. And I very creatively put that on the screen because telehealth policy has been a long road for telehealth policy. People have been talking about telehealth as the future of healthcare for 20 years. And particularly at the federal level and the policy level, they were met with resistance, primarily for concerns due to cost and a few other concerns about really is telehealth the future. In response to COVID, it became the obvious solution. As you all know, healthcare volumes declined dramatically in March and April and May, and telehealth was the obvious answer to address that shortcoming in volume. Just to be clear on where Medicare was at the beginning of the year pre-COVID, I'm going to start there, then we'll talk about what the changes were in March and then what the future is. I will note, and I would maybe rely on Rondianne to confirm this, I think Oregon Medicaid was well ahead of Medicare in terms of telehealth policy. So Oregon Medicaid might have been more advanced than Medicare going into COVID. But with that said, where was Medicare in terms of telehealth? The only kind of telehealth visits that Medicare paid for was 1, patient has to be in a rural area. 2, patient has to drive to an originating site. So they can't do it from the home. They still have to get in their car, drive to the originating site. 3, patient had to use a secure HIPAA platform to communicate with a provider at a distant site. Okay? So those requirements essentially limited telehealth to patients in rural areas that needed to see a specialist that wasn't available in their town that might be available in the city. So that was really the only scenario. Okay. So very limited. If you were in Manhattan or any urban area, Portland, forget about using telehealth, right? In response to COVID, the federal government got rid of pretty much all of that. They said, 1, patient can do telehealth policy wherever they have internet connection. They got rid of the originating site requirement. 2, they said, forget a HIPAA compliant app. Those are ridiculous. We're going to go with, if you want to use Skype, Zoom, Cisco, WebEx, whatever it is, you're good to go. 3, they allowed distance site providers to provide that service anywhere, right? So all of a sudden, they said you can do it in the city. So people in Portland could do it all of a sudden, right? So those 3 things dramatically opened up telehealth policy, and now you could do a telehealth visit on an app that you probably already had downloaded on your phone with your provider, and it wouldn't have to be just to see a specialist in some other city, right? So that greatly opened up telehealth policy, and the government did all of that via waiver authority under the public health emergency. What they didn't do, though, at that time in March was allow rural health clinics to be a provider on the other end of the screen. They said, and I disagree with this, but they said that they didn't have the legal authority. I think they did have the legal authority to do it in March, but they said, we can't do it. And so they said, Congress, you have to give us the statutory authority to do it. And so Congress in the CARES Act didn't fully listen to us, but they partially listened to us. And they did extend the ability to provide distance site providers to RHCs, but they created the composite rate payment scheme specifically for RHCs for telehealth that we, quite frankly, don't really like. So that's what happened. That's how we got to where we are. Okay, next slide, please. Before I dive into too much of the details, I do want to just make it very clear that telehealth is a buzzword. And telehealth can mean multiple different things to different people, depending on the context. Complicating matters further, telehealth is an umbrella term that can properly refer to a whole variety of services. So when someone says telehealth, you have to pause them and figure out exactly what kind of telehealth service they're talking about, particularly in the context of Medicare. For example, on your screen, and this is very similar to the different allocations that you've received, you have to have these categories properly sorted in your head. For rural health clinics, starting in 2019, we were able to build something called a virtual check-in or virtual care communications. Okay, so this is pre-COVID, we were able to do this. On the fee schedule, they built G2010, G2012 for these two services, but rural health clinics have special ways to bill all the different types of telehealth services. We collapse the fee schedule codes into one code. So our code is G0071. So this was the policy established in 2019, okay? And just maybe I should back up here. What is a virtual check-in? This is the government's attempt to get patients and doctors to use the patient portal, okay? They're trying to value provider time answering questions, essentially, that the patient submits on patient portal, right? Whole concept here is that we can take care of and value new types of interaction between patients and provider in a way that, you know, is preventive in nature and actually saves the government money over time because, you know, the patient's getting, you know, feedback through the patient portal, right? So that's the concept. They call it a virtual check-in. On the fee schedule side, they have two codes. For rural health clinics, we have one code. Started in 2019. No one billed it. No one billed it as far as I know, because in 2019, the payment was about $13 and it just wasn't worth it for most providers. And it goes against the traditional thought of what an office visit is and what a doctor's office does, or a rural health clinic or a PA, a nurse practitioner does, right? So this is, in my view, it is the kind of communication that is going to be more and more important in the future as more and more healthcare communications are done online. But you will note that nowhere in what I just described is live interaction, right? It can be a phone call, but it can more likely be responding via either text or email to patient questions through the patient portal. Not face-to-face though, right? Flash forward, and again, virtual check-ins started 2019. Flash forward to 2020, and Medicare started this similar but slightly different service called digital e-visits. Fee schedule providers could start doing this January 1, 2020. Rural health clinics, CMS did not create a way for us to bill these initially. These are excuse me. These are very similar to virtual check-ins. They are essentially online digital E&Ms that over the course of a week, you spend time going back and forth through some sort of digital method with the patient, giving them advice. Okay. Fee schedule side, they have 3 different codes that are valued based on like the time spent over the course of the week. Again, Medicare did not have a way for rural health clinics to bill for that. In that March moment, sorry, I'm getting a call. In that March moment, CMS did say, okay, what we do have the waiver authority to do is we recognize that we didn't bring digital e-visits to rural health clinics in 2020, so we'll let you bill your virtual check-in code G0071 if you do a digital e-visit. So that's what they gave us. And that policy is temporary, only exists for the public health emergency. Anyways, all of that changed the payment up from $13 to $24 for G0071. And I suspect that most of you aren't doing any of this, right? But and the reason I spent so much time on it, this kind of communication between patient and provider is in many ways seen as the future of healthcare. And we're going to need to start figuring out the reimbursement at a more sophisticated level for rural health clinics. I personally hate the way that the government is collapsing all of these different services into one code for RHCs and paying us the average. But that is the process that we're stuck with right now. And we have to kind of fight each time they create a new code that's a new variation of a telehealth service. We have to fight Medicare to value that code for RHCs. Okay, so virtual check-ins, one level, digital e-visits, another level. Now, telehealth visits. Telehealth visits is probably, when someone talks about telehealth, what they're talking about. That is the substitute for in-person services. The billing and coding for that is exactly the same on the fee schedule side. So fee schedule side, they're doing an E&M 99213. Person comes in person, they bill 99213. Patient does it via telehealth, they bill 99213. Right? So the service provided is a level 3 E&M. It is a level 3 E&M. On the fee schedule side, it's just one was in person, one was done via telehealth. Okay? So in that sense, they are substitutes for in-person services. Okay? But as I mentioned, Congress in the CARES Act basically created a special reimbursement rule for rural health clinics and FQHCs. That special reimbursement rule is that we receive, quote, a composite rate for all telehealth services. And so what the government did is they took a list of 238 things that our fee schedule friends can bill, and they took the average of it, and they said that's $92.03, and that's what we'll pay you for every single telehealth visit, no matter what you're doing. The coding and the billing for it is always, if it's a telehealth visit, G2025. That is the system that the government set up in the CARES Act. I do not like that system. I would like to get it changed. I will need your help to get me changed. Get it changed. And we'll talk about that in a second. Last thing I'll point out is that audio only, there was, for a brief period of time, audio only had to be kind of collapsed into the G0071 code. But now the government has clarified that there are a variety of services in that list of 238 that can be done via telehealth that can be audio only. And so essentially for us, since we collapse it all together in G2025, we can bill audio only telehealth services as G2025 services, which always pay $92.03. Doesn't matter what your all-inclusive rate is. Doesn't matter if it was a quick 5-minute call or an hour-long call. You're getting paid $92.03. Next slide, please. I'm going to skip a lot of this, other than to say MLN Matters SE 20016. That's your key document if you want to dive into the details of how telehealth works for RHCs during the public health emergency. Next slide, please. The link at the bottom here is the Medicare maintained list of the 238 CPT codes that our fee schedule friends can bill via telehealth. Again, for us, if you do any of these 238 codes, you can bill it, but you have to bill it as G2025. On that list, you will see there's a column that says, can this service be done via audio only? If there's an X there, it can be done via audio only, meaning you can do it audio only. But again, we collapse it all into G2025. One last note on this, all costs associated with telehealth visits must be removed from the cost report. Another reason I really don't like this system. Next slide, please. Furthermore, if we fail, and I fail, in getting this changed before the end of the public health emergency, and God forbid, but the composite rate policy gets locked into place, CMS is paying it wrong. Which is another problem. The current policy, and this is not the MAC's fault, it's CMS's fault, because they told the MACs to do it this way, is that the MACs pay $92.03 minus the coinsurance charged to the patient. But what we believe the policy should be is that MACs always pay 80% of the composite rate, or $92.03. And the coinsurance to the patient doesn't impact what the max reimbursement to the RHC is. If you followed that, good for you. If you didn't follow it, think of this. The higher the charge to the patient on a telehealth visit, the less the MAC will pay you. The smaller the amount of the charge to the patient for a telehealth visit, the more the MAC will pay you. Does that make sense? No, it doesn't. It's wrong. We're trying to get it corrected, but I want to scrap this whole payment system and replace it with something better anyways. But if they lock into place this bad one, this is a nuance that needs to be fixed. Next slide, please. All right, so what are we doing? On September 23rd, we sent a letter to congressional leadership, really staking out our claim on where we would like to go on telehealth policy. You can review and read the full letter on our website. But essentially, we need to do two key things before the end of the public health emergency. One is we have to first extend the ability to provide care as distance site providers. Because currently, if Congress doesn't pass an act of Congress before the end of the public health emergency, everything snaps back to pre-COVID policy. And basically, telehealth is back to that very limited purpose in the context of Medicare. So first thing we need to do is get Congress to pass a law, extending telehealth beyond the public health emergency and extending explicitly the ability for RHCs and FQHCs to provide telehealth visits as distance site providers. Okay, so that's step one. Step two is that we got to take this composite rate system that they've concocted and throw it out and get something better. We would like payment parity between face-to-face services and telehealth services, just like our fee-for-service peers get. So my ideal world, whatever your all-inclusive rate is, that's what you should get for your telehealth visits. They are, again, replacements for in-person in-person services. If you're doing a 99213, whether it's in person or via telehealth, you should be paid the same way. That's how it works for our fee-for-service peers. It's how it should work for us. All right. Couple of good news items, okay? If you look at the letter on the screen, you will note it's from 3 organizations: my organization, National Association of Rural Health Clinics, National Rural Health Association, no surprise there. We worked well together. But it's also from the National Association of Community Health Centers. Because FQHCs are in the exact same boat as rural health clinics on this issue, it is not a rural issue. It's an urban issue as well, meaning that congressmen and congresswomen from the middle of the city all the way out to big rural districts all have a vested interest in this because they probably have an FQHC or an RHC in their district, right? So it's not just rural. Other good news is that we have multiple pieces of legislation that are all bipartisan that would all fix aspects of this policy. Next slide, please. I don't expect you to review and understand all the differences between these pieces of legislation, and it's really not that important. This is just to show you, and this is actually an incomplete list. There are tons of different pieces of legislation, all have slight variations that fix this the way we want to fix it, okay? That's the good news. The bad news is that it kind of complicates our messaging. There's not like one clear solution that everyone has coalesced around. So next slide, please. What we're asking for is, instead of focusing on this legislation versus that legislation, we just need to focus on what we're going for. 1, extend the ability to provide care as distance site providers, and 2, fair reimbursement for telehealth services relative to our fee-for-service peers. That's what we want. We don't have that now. That's what we're fighting for. Again, for RHCs, that means normal coding, normal billing, normal reimbursement, and normal cost reporting for all your telehealth visits. That's the policy we aim to achieve, and hopefully with your help, we can get there. Next slide, please. Can't do it alone. When RHCs were excluded from telehealth back in March, and the administration said, well, Congress needs to fix it. For about 3 or 4 weeks, the RHC community was absolutely fired up, and they said, this is an injustice. My friends in the fee-for-service world can do telehealth, but we can't do this. We're in the middle of a pandemic, and Congress, Capitol Hill offices were reaching out to me saying, Nathan, what's going on? What can we do? I'm hearing that you guys can't do telehealth. That was the most fired up I've ever seen the grassroots, the rural health clinic community. We need that kind of energy and effort if we want to get the policy I just enumerated on telehealth long term. So it's got to take both inside the Beltway, I'm inside the Beltway, plus grassroots advocacy in order to achieve that. So with that said, I want to make sure I leave time for questions. Obviously, I have some links on the screen that talk about some of our advocacy efforts, but we really need grassroots advocacy. So I highly encourage you to begin to have a relationship with your congressional representatives and your senators and their staff, their health staff, particularly, quite frankly, Senator Wyden is the most influential Democrat on healthcare and Medicare policy because he's the ranking member of the Senate Finance Committee. And by the time you all hear this, he might very well be the chairman. So with that said, next slide. I think that's all I have. There's my contact information. I think we'll leave time for the Q&A.
Thank you, Nathan, for the Washington update. That was awesome. Thank you so much. We will now go to the question and answer session. Hello, everyone, and welcome to the portion of the Q&A session. Please use the Q&A box to add your questions for the presenter, and I will start off with the first question. Nathan, are you ready?
Yes, can you hear me?
Yep, you're great. Okay, what is the status of the Modernization Act?
So the Rural Health Clinic Modernization Act was pre-COVID our big policy focus. It addresses the rural health clinic, what we call the upper limit, or more commonly known as the cap, and it tries to make it a fair reimbursement for our independent rural health clinics that are really struggling. So that will no longer be valid in the next session of Congress. And so we plan to get it reintroduced. But this time, the tweak that we're making is that we think we have a much more comprehensive and detailed policy that we can put forward that actually pays for itself. And we hope that that will give it the legs it needs to really get across the finish line sometime in the next 2 years.
Okay, perfect. Will RHCs get an allocation for vaccine distribution?
This is a good question. I don't know. I think that the vaccine, the vials itself will be distributed, as in the government will completely control the supply, and you won't be purchasing any vaccine vials or vaccine kits. So a little different than, I think, testing. The government has also come out and said that for the administration, the cost of administration, rural health clinics will be paid the way we are paid for our flu shots and for our pneumococcal shots. So essentially what that means is that we keep a log, and at the end of the year, we get reimbursed a lump sum for our the patient, our Medicare patients that we've vaccinated. That's very different than our fee schedule peers will be paid for vaccine administration. They will be paid, depends on if it's a single dose or a multi-dose, but they get paid basically a flat amount per per vaccine administration event. We won't get paid until the end of the year, and it'll be a lump sum payment based on our costs of administration. So very different for RHCs than for fee schedule providers.
Thank you. And the last question I have is, when will the PHE end?
Technically, it ends every 90 days after it's renewed. It was last renewed about October 23rd or 25th, somewhere in there. And so 90 days from that puts you around January 23rd or 25th, somewhere in there. I project that they will extend the PHE, whether it's Secretary Azar or Joe Biden's Secretary of Health and Human Service. They will extend the PHE for quite some time because there's so much policy tied up to the PHE that they're just not. They don't have a way to land or to sort of evolve the policy beyond the PHE. So they will buy themselves more time to figure out what they're doing on things like telehealth, for example, before they pull the rug out and say, "Oh, we're back to pre-COVID policies."
Okay, thank you, Nathan. This concludes the second day of the RHC workshop. Thank you, Nathan. You were sensational as always. On behalf of the entire staff at the Oregon Office of Rural Health, thank you for attending the 2020 virtual RHC workshop. We hope to see you all in Bend in 2021. Be sure to attend the virtual 2020 annual Rural Health Conference November 9th through the 13th with a special presentation on November 19th. Finally, RHCs, if you would like a virtual mock survey, need a resource, or just have a question, I'm here to support Oregon RHCs. Thank you and be well. Thank you, Nathan.